Hello. So I'm Yevgeny Zadov. This is following Dr. Body's presentation on dystonia. Here, I'm going to be more like the patient, only the patient who happens to have dystonia. So we'll kind of talk about what I went through from a patient point of view as somebody who also knows like the medical world. So to give you an idea, I got diagnosed um, in the fall of my last year of school, of med school. So I was trying to do the match and step two of boards while having dystonia as a new diagnosis. Probably the biggest challenge with people who have dystonia is the delay in diagnosis because the initial presentations are so varied. I've talked to a lot of other patients who have this. For me, it was just headaches for a while, for a good 3 to 6 months of maybe occipital pain, headache. My primary care doc, who was one of the attendings at the school I went to, thought I was having stress headaches. He also thought maybe I was having stress-related spasm. I have a family history of tension headaches, so the thought was there was something going on in that direction. It took close to 6 months for the doctor to kind of tell me, you know what, I think this is more neurological. And at the time, all I was having, there was no postural change. There was nothing going on with that. Um, there was no evidence of tone day to day other than as a DO who did OMM, he said, well, your neck is tight. Um, but it kind of got worse with time. And um, what happened was I diagnosed myself on the morning of my first uh, interview for residency for PM&R, which was kind of funny. So I try to play it off as I, just slept around. I wound up going like this the whole time during the interview. I couldn't move my neck at all. Just to give you some background, right now I get 500 units of Botox every 3 months, usually lasts the whole time. I had DBS surgery, bilateral lead placement, about 5, 6 years ago at this point. So I'm doing a lot better now than I was, but just some background there. I would say that other than delay, the other thing is the initial symptoms are sometimes hard to catch. The book definition that we use of dystonia, of that altered tone, of those spasms being, velocity dependent and all that kind of stuff. Um, it's hard to detect when you're the patient. It's hard to explain if you don't have the anatomical knowledge that a doctor does. It's very hard to explain. We can't move your neck. It only hurts when you do certain things. You feel crazy and you feel like you sound crazy because you can't explain it. So I would say, if somebody's describing this kind of stuff, just reassure them and maybe specifically look for what they're talking about, especially since stress is known to make the symptoms themselves worse. So, one of the things I've had to do was manage my own physicians, the neurologists and the primary cares that I've had as doctors. Because of this, I've been tied to having a doctor rather than being the doctor for most of my career. Um, that just says shotgun medicine and snipers. So I'll explain what I mean there. Um, the definition of dystonia is that the spasm isn't painful. Um, I would beg to differ. I think that if it's a spasm in a muscle that you have to move to be able to do basic ADLs, to be able to stand up, walk to the bathroom, brush your teeth, shower, use the facilities, go to work. In my case, it happens to be in my neck and in my back. Those muscles move whenever you move. So moving a contracted muscle, whether we're going to call it a spasm or not, it is shortened. That is painful. It will also cause secondary dysfunctions. You'll have, uh, if you do anything physical, you can easily herniate a disc if you have anatomical dysfunctions. Like, for example, my whole back is side bent to the left, rotated to the right, uh, the whole thing. So it looks like I have a rib hump and scoliosis on the right side. My scoliosis is purely neurological. It goes away when I sleep. It's only there when my tone is increased. It decreases when my Botox is working well. It increases when my Botox wears off. So I would say that looking for a painless spasm may be futile. So just something to think about. One of the things that I discuss with my neurologist, so the issue with being a physiatrist when you go to neurologists is that they're not quite as good with understanding the functional limitations of their patients as we are. I would like to think. At least we should be better. And that's not a slight on them. We should be better. That's what we do. So sometimes I've had to explain what it is that I can't do or have trouble doing or have pain when I do in much greater detail. And that does help, especially when I was seeing the person that I was seeing before Dr. Bhatti. It took a little bit, but we actually got along very well once I explained what it is that I was having trouble with. Um, what I mean by shotgun medicine and snipers, not spinners, excuse me, is that when we treat something, we sometimes treat the symptom rather than the specific disease, right? Sometimes you need to treat the thing that brought the person in to you in the first place before you can get to the underlying cause. So, for me, um, it's about making sure my neurologist and my patients, when I have dystonic patients or anything else, we've taken care of the things that cause them the most discomfort, however we can, and then they can start to pay attention to more of the symptomatology that we have read about, especially when we're just starting out, because dystonia is not something you see a heck of a lot of as a physiatrist. It's not something you see a lot of as a neurologist either, because that's why it's a subspecialty as a movement disorder. So if you do get somebody who has dystonia or dystonia comes up as a thought on your radar when you're talking to them, make sure you can get them comfortable enough with their pain, with their ability to really talk about what it is they're experiencing before you just go and try to make a very specific diagnosis of cervicothoracic dystonia, cervical dystonia, torticollis, whatever. Just keep that in mind. Uh, so one of the things that I've had to deal with quite a bit is work accommodations. Now, I actually don't need any at this point. At one point or another, I realized that I did because things would take me longer. It takes me longer when I started being an attending to walk down the hallway. One, because my back hurts all the time because there's a high amount of tone. Uh, I don't look right when I walk. It's painful. It's uncomfortable. I take a little break here and there. So whereas seeing 20 patients on rounds can take you an hour or so, maybe an hour and a half if you're rounding with some students or something. It would take me longer. Right now, I can round relatively quickly. I got used to it. I made those accommodations. But the problem with ADA accommodations is they're not designed for this. They're designed for people who can't lift, push, pull, that kind of stuff. They're very specific things. So if your patient has work accommodations, that's something to definitely think about and talk to them about what part of their job is difficult. Yes, they can type, but how long can they sit in that chair and type before their neck needs a break? So at one job I had, when I wasn't doing that well, they actually got me a specific ergonomic chair that helped quite a bit. Uh, as my management and my symptoms got better after I got DBS, I didn't need any of that, but it's something definitely worth noting and worth thinking about. Um, Dystonia has storms. Dystonic storms are a little bit like um, sympathetic storms in many ways, in that we we as patients can't control what causes them. Sometimes it can be a small stressor, it can be something that is stressing us emotionally. Unfortunately, something that might make your jaw tighten a little bit and you might grit your teeth when you're angry or something like that, and move on with your day. For somebody who's dysonic, that may set off a a storming episode, not necessarily sympathetic in the classical sense, but it may set off a dystonic episode. So keep that in mind, and talk to your patients about what they can do to manage those episodes. Sometimes they last a while, sometimes they last, a few minutes, sometimes it could be days or weeks. I've heard patients tell me a bunch of different things, but I think that it's something worth talking about when we're talking about how their job is going to accommodate them. So, for instance, one of the things that I do for myself is I will round and I will see a bunch of patients, and then I will go home, get comfortable, and do notes. And that might take me longer than an average bear. And I might take a break, and I might, do a couple of hours of notes here, a couple of hours of notes there, maybe an hour here. Uh, Maybe I'll take somebody else an hour and a half and they're done, and I might break that up into 3 hours of work, something at 6 p.m., then take a break, then do something at 8, do something before I go to bed. If somebody's job can accommodate for them to get paid for 8 hours a day, as long as it's spaced out, that might be something that's more reasonable for somebody who is dystonic and has trouble sitting in one spot, keeping their head up and, on a keyboard and keeping their head straight. So as I sit here, my head is turned. That is, I don't even know that I'm doing that, just to be honest with you. If I look in the camera and straighten my head, like, I think my head is straight now, but I am using a fair amount of energy to do that. If I had to type as well, that would be difficult. So just going to keep that in mind. One thing I found, and this is interesting, is doctors are kind of like used cars. And I find this for myself as well. The patients we've had in the past tend to color our experience with what to expect, whether it's age, disease process, whatever else. It's well known that something like fibromyalgia as a diagnosis can give us a certain mental picture of what's going on with the person, psychologically as well as medically. And there were times in the past where that diagnosis was not as well understood by a lot of physicians as it is today. So I would say that keep in mind that the dystonic patient has probably seen a lot of doctors. Um, they're used to being, they're used to having a hard time with physicians trying to explain what it is they're feeling, especially since they may not have the words to do it. They're grasping at straws, trying to explain what they're dealing with. So kind of be kind to them. I'm sure you guys are, but understand that you're just another doctor that they may not expect will be able to help them. Maybe they expect to be dismissed outright. I've heard that a bunch of times. Um, with moving, so I moved quite a bit, I know, from residency to a fellowship to being an attending in a couple of different places. The worst thing I can do is not know who my neurologist is going to be. If at all possible, I should be able to be to meet with them uh, before my 3 month Botox appointment is due. Sometimes it hasn't been possible, and it's been quite difficult. So if your patient is moving, try to make sure they get in touch with a neurologist. Try to make sure their insurance is lined up. All those things are something worth talking to your patients about if you can, because if I miss a Botox dose, I have a hard time even just working. So I would keep that in mind. Let's see. That was basically it. I would say that as a doctor who has this thing that's not really taught in medical school, it's only taught, in a subspecialty of neurology, and sometimes we hear about it in rehab. Um, be aware that it exists. Be aware that as hard as it is to for a neurologist to explain to us without seeing a patient with this, it's much harder for a person who has it to explain what they're going through. So just again, keep that in mind. And if you have any questions, feel free to reach out through the academy and we'll get in touch. All right. Thank you.